Welcome to Voice from the Field, the NAMA Next Gen podcast. I'm your host, Neil Nakkash. The way health systems and professionals collaborate plays a critical role in improving healthcare across the globe. In this episode, I speak with Dr. Joseph Kolars about his journey into global health, what it takes to create sustainable international partnerships, and how the next generation of physicians can be better prepared to engage in global health work. Dr. Kolars is the Director of Strategic Development for Global Collaboration at the University of Michigan Medical School and co-director of the Peking University and University of Michigan Joint Institute for Translational and Clinical Research. A practicing gastroenterologist, he previously served as Senior Associate Dean for Education at the University of Michigan Medical School, where he oversaw medical education across all levels for more than a decade. He is also the founding director of the University of Michigan Center for Global Health Equity. For decades, Dr. Kolars has worked to strengthen health professions education and healthcare systems through long-term partnerships, with a focus on building equitable collaborations and preparing the next generation of healthcare leaders. We're incredibly honored to have one of the nation's leading voices in global health with us today. So without further ado, here's my conversation with Dr. Kolars. Thank you so much for joining us, Dr. Kolars.
Yeah, it's
So,
really a pleasure to be with you today, Neil.
So I first really just wanted to really discuss your journey towards global health work. You're, of course, a practicing GI doctor. You trained here in the Midwest, and this is not necessarily the background people might immediately associate with global health leadership. So what was it that drew you toward global health work? And, how did your journey evolve from clinical medicine into larger things like health and education systems?
Sure. Well, Neil, as you can tell by looking at me, I'm more late career. But I can't say I really plotted or charted out. I'm in the best place I could ever imagine, but I couldn't see this destination from where I was as a student. To directly answer your question, it was during medical school. I always had this interest in the world, international settings, and I happened to structure a international rotation, a foreign experience. I saved up all my electives to the end of my senior year. Ended up going to India and Nepal. In India, I was had a chance to work with Mother Teresa for a bit, but I was largely in a hospital in Bihar, India, and then had a chance to work in a hospital in Western Nepal. And these were incredibly rich but disruptive experiences. I thought I was just going kind of as for tourism and a chance to maybe see what another healthcare ecosystem looks like. But where I became really disrupted is it challenged my assumptions. I could suddenly see different aspects of healthcare, different aspects of needs, how people's context and culture influenced what they were looking for. And I could also see our own healthcare system from a foreign land
Mhm.
and started to question why are things this way back in the US, and how can we learn from other systems, other cultures? So uh, I felt like this was the most transformative aspect of my student experience in medical school. And I said, gosh, I wish everyone could have this. If I could make a rule, everyone would have to get out of their own culture, their own system. So that's where I got the bug, so to speak, for global health and global experiences. And at my core, I'm a medical educator. I happen to differentiate into gastroenterology. And when I'm in this culture, when I'm at University of Michigan, that's my clinical identity as a gastroenterologist. When I'm in the global sector, I'm not doing gastroenterology anything more than general medicine and general care, public health, population health. But my common denominator has always been medical education.
Most definitely. And I think you brought up a really good point about when you went to India and Nepal. You mentioned that, sure, at first you might have gone for tourism, but it showed you the ways other health systems have something to offer towards us in the U.S. And part of your work in global health has really been focused on sort of sustainable development, mutual development with global partners. How did this experience really inform that, and how do you try to do that in your day-to-day work?
Sure. Um, one of the aspects that that was really imprinted on me from my early global health experiences is what a difference a system or a context makes in
Hmm.
terms of health and healthcare. Um, I really resonate to this truth, to this piece of knowledge, and that has to do with the question, what what determines a person's health? And sometimes we don't ask that question enough. But when you look at that from the research or scientific viewpoint, about 50% of a person's health is determined by their genetics. About 40% is the social determinants of health, the
Hmm.
situation into which they were born, their education, what's their family's economic and social status, things like that. So that's a huge piece, social determinants. But only 10% of our health is determined by health care. But at least in the United States, that's where most of our money goes. It's into
Hmm.
health care. And it's really put our economies often into a tough place. So more attention needs to be placed on those social determinants and how to keep people healthy or prevent illnesses rather than all the money we spend at the end of it. So one of my hopes in the global health environment is to help other systems wrestle with that. I think the
Yes.
worst thing that can happen is if people start to duplicate every aspect of our healthcare system here in the US. I worry about that
Hmm.
because we have a number of good things here, but we have a number of things that are not so good and not sustainable. So hopefully, these other evolving cultures will leapfrog over us and come up with something new and better. One of the other aspects of your question prompts me to talk about one of the other things I observed early on is just the art and science of collaboration.
Hmm.
Um, Global health was founded on kind of a colonial principle. How can we keep our soldiers healthy when they go into foreign lands? How can we make our businesses prosper when they go into foreign lands? Often with lower income levels than us, but it could be really seen as colonial and extractive, as opposed to how can we go in and truly meet people where they're at,
Hmm.
collaborate, co-create, co-design, so that we're not coming in and just laying on our agendas. So one of the things I learned very early on, just by observing, is to see how local groups would respond to people like me coming in, and who are getting into really synergistic collaborative relationships, as opposed to who are kind of into these transactional relationships. Will you help me get a
Hmm.
grant
Yes.
or do something that's going to advance my career? So those were some pretty powerful lessons that I learned later early on.
I think we're gonna really get into a lot of these lessons and themes that you're speaking on, especially the sort of um, inherently colonial aspect that might come to doing global work. But first, before we even get into that, I wanted to ask about your experience in Shanghai. So you spent a period in the 1990s helping develop one of China's first um, Western-based health systems. Can you speak a little bit about that experience and which lessons you tried to take from, U.S. healthcare, other systems, and trying to bring them into that new context?
Yeah, that was an interesting part of my journey, uh, creating a new healthcare system in China, specifically in Shanghai, where I moved with my family. And it was a curious opportunity. They gave me the first license they had ever given a non-Chinese physician.
Mm.
And one of the goals they had is that they wanted a Western healthcare system to help support their burgeoning international community. As you point out, this was the 90s. Shanghai was becoming more and more the economic engine for China, having more and more of an international community. But people were hesitant to move there or to move their families there because they really didn't have the kind of healthcare infrastructure that they were familiar with in the U.S. or other Western health systems. China system was still evolving, a lot of traditional Chinese medicine, a lot of Russian-based systems, but it just wasn't familiar or comfortable. So one of the big goals of the government, the school where I was working there, was to provide a system that can take care of the international community.
Mhm.
What ended up being an enormous surprise to everybody was that Chinese people wanted to come to this. Um,
Mm.
uh, we expected them not to come. This is foreign. This is not part of their culture. It's much more expensive than the local situation. But what was attracting them was just a different aspect of what they perceived to be quality. Also, there's this otherness factor. Sometimes when people are a little restless with what they have or what they have isn't working, they look to something other. Um, I see that a lot in our culture here in the United States. There's a lot of attraction towards traditional Chinese medicine. There's an otherness there, and there's also some really good aspects and positive attributes. And for a lot of people there, wow, they were really attracted towards this otherness of Western medicine. So, to your point, to your question, Neil, what were some of the lessons learned? One of the things I really had to learn is to understand better what people were looking for. In our culture, we kind of have a sense of what people's expectations are, and that's why they came to this particular moment or this particular person. But I had to spend a lot more time unpacking what people's needs and what was driving them to actually seek out this particular care and to really understand where they were coming from. Um, and that was a really powerful lesson. Another powerful lesson was spending a lot of time trying to understand how I was perceived by others.
Mm.
Um, here I am, an outsider coming in and practicing medicine. Suddenly, I've got a medical license. And how are the other doctors and the healthcare workers and the leadership, how are they perceiving that? So I had to spend a lot of time understanding how I was being seen and how I was being understood so that I could form effective collaborative relationships and leverage up from there. I got really in touch with how often I operate under assumptions, and I don't necessarily check those assumptions with how patients, colleagues, other providers there were seeing me. So some pretty powerful take-home messages for me.
I can only imagine because I think when you're discussing these assumptions, it could come from both places. Oftentimes, people in the countries that you may be doing work in having an assumption about you that's rooted in sort of the history of global collaboration. How have you gone about addressing that, addressing those assumptions and ensuring that the global collaborations that you engage in are something that are specifically long-standing, mutually beneficial, and really don't veer into that sort of one-sidedness that we sometimes hear about, where it's like sort of the higher or more economically adept nation coming to help the lower or middle income country.
Good question. Um, Two components of my approach really leap to mind. Um, One is I really try to emphasize appreciative inquiry when I'm
Hmm.
starting off in a new situation, a new collaboration. All too often, people like us come into settings and they think they know what is needed and what is required. They have something good that they've been doing that they want to do here. But I really try and spend most of my time initially asking questions and
Hmm.
trying to understand the local situation and where people are at. Um, and really try and again look and see how they're looking at me as well. Often I'm in low income countries, low income settings, and it's hard to get at what people are looking for when they're looking to people like me as being a source of money and resources. And, as much as we try and say, well, what do you want to do? What's important to you? In the back of their mind, they're going, you've got the money. what is it that you want to spend it on? And so it's this dynamic that needs some work, but bringing appreciative inquiry to that dynamic, bringing humility to that dynamic has been really important to me. A second component of the approach that is really important to me is first working on creating a relationship. So many times, people in the US, my culture here, they're a very transactional people, and they'll go in to a global situation and be transactional. Well, there's
Mm,
this grant opportunity. I see this problem. I've got an idea to solve, but they want to get at what it is we're going to do. Very transactional. Most of the world, or at least low income parts of the world, they first value a relationship. And I learned this in China. Don't first come in figuring out what you're going to do together. Try and figure out how
mm,
you're going to be together
mm,
and see if you have common values. See if you like each other. See if you're motivated by that relationship to do something. So first craft the relationship, and then let it evolve into doing something. Um, Again, I see one of the common American approaches from our culture and what's played out in global health is people will they'll come in and say, well, let's do this. Let's plan our study. Let's plan our intervention. And in the back of their mind, they go, yeah, I hope we get along. I hope we have a relationship, but it's not as important as the doing. And this feeds into, the essence of your question. How do you make things sustainable? How do you build for the future? And again, that depends on, well, you're building relationships. You don't think of friendships as defined contracts. But there's so much in global health where the relationship has only existed because of a certain grant or something like that. But one of my approaches has been trying to emphasize our relationship in the kinds of things we could do together and create, or even just be supportive from a distance to each other.
I really hear these insights and I've seen them, be put in practice at those events organized by the Center for Global Health Equity. So I really commend you on that because I believe it was Dr. Moyer where she hosted a session at the Center for Global Health Equity at the Rackham. It must have been early January of this year, and I remember just like taking her insights where she really discussed thinking about global health as relationship building, really having that focus on it because it just changed the way that I wanted to, work with the global partners that, I've come to know. So on that point of the work that's done by the Center for Global Health Equity, you are, of course, the former founding executive director. Um, when you went into establishing that center, what was, I guess, a gap that you saw in global health work done by academic institutions that you really wanted to address? And I guess I really see that equity piece. A lot of places might just be called the Center for Global Health, but you really put equity front and center. So really just wanted to ask about your motivations with that as well.
Sure. Probably the biggest motivation was the opportunity to bring different thinking or different disciplines to global health problems. Um, in academic institutions in the global environment, often people are competing with each other, and and you know uh, grant opportunities or partnership opportunities. They want to get into the best position possible. But and then what that ends up is that you can find a lot of global health approaches that can be dominated by a discipline. Oh, this is mainly about public health people, or this is mainly about doctors, or this is mainly about nurses. But there haven't been a lot of drivers or incentives for people to play across boundaries and to
Mhm.
say, how can different disciplines and different ways of thinking really be applied to a problem? So one of the big drivers for the Center for Global Health Equity is, we're a public university. We're a great public university. We have all these schools and disciplines. We have about 8,500 faculty, but because of academic incentives, often people stay within their lane and they're just doing things on their particular branch of the tree. And there aren't a lot of incentives or opportunities to get completely outside your discipline and learn from somebody else. So the foundation for the center, and one of the big things that we do is how can we bring people together from across campus that people aren't used to working with or thinking with to come up with solutions. And again, I go back to that earlier figure, only 10% of your health is determined by health care. But we've got all these other people working on the social determinants and other things. So when we take a project, rather than just having maybe a doctor and a nurse, but wow, what would happen if we brought an anthropologist into
Hmm.
the discussion? What about bringing somebody from the business school to think, well, is there an entrepreneurial opportunity to help people make money here? What about, engineers are problem solvers. What if we brought engineers into this picture? So one of the things our center does is it gives grants. You can't get a grant unless you've got three different schools or three different disciplines involved, because we want that different co-creation of people. So members of our center come from across the campus. This is not just a Michigan medicine show, but we've got, our School of Environment and Sustainability, our School of Social Work, um, uh, information, the people from LSA. So, and it's been fun to watch because a lot of times these people are not used to working with each other.
Hmm.
But suddenly, when there's a problem, there's an opportunity to do something impactful in a low middle income setting. It brings people together in creative ways. So that was one of the really new aspects. At the time, there were no other centers of global health equity. That's now a really common term out there.
Hmm.
And I can't say there were other centers that we saw around the United States that were really playing to their whole orchestra of people across campus, but that's been a real crucial aspect of our success.
I think it's very impressive to see. I think about all the CGHE events that I go to. I've met, as you said, people in environmental science like Dr. Vidal Butt, social scientists like Dr. Moyer, all sorts of physicians in different specialties. And I really do like that emphasis on multidisciplinary work, interdisciplinary work, because again, no single specialty has the answers for these very real and large problems. So I think this is a great direction, for other centers to take as well. Point of physicians sort of sticking to one lane. Oftentimes people's career paths or physicians' career paths, some might only stay as clinicians, some might, focus more on academics as researchers, but you've had a very broad career across research, clinical care, global health work, of course, administration, education. What was it that really led you to really want to have all these different dimensions of medicine involved in your career?
Sure. I guess I would have to say, Neil, that it was just the attractions of the moment.
Hmm.
Um, as physicians, we're extremely privileged people. Probably it's an outsized privilege that we have to be very careful of. We're highly regarded by society. The salaries are good. The prestige is really high. And the foundations of our preparation are dealing with the people that's in front of us.
Hmm.
So it's that hospital care, it's that clinical care, but again, it's only 10% of the equation.
Hmm.
And a couple things that drew me out of just that dynamic. I still do a lot of patient care, but what drew me out of that dynamic was just looking to see all the other aspects of the system that kind of can influence a person's care. And I had this restlessness of, wanting to make things better. I think it's common across so many humans. They want to make things better.
Hmm.
And And, doctors are drawn in because they want to make patients better. But then there's a generalizable aspect there where, well, I want to make systems better. And, um, and doctors go through a long period of training. I had a real restlessness that I wanted to make education better. I
Hmm.
found it so highly variable. When I had a when I had a great teacher or a phenomenal learning environment, wow, it was a thing of beauty. It was just so energizing. It was so addictive. But I have to say, most of my education wasn't that way.
Hmm.
I spent a lot of time with so-so teachers or so-so learning environments. But what was clear to me is that it could be different when you see examples of things that are just so dynamic and so creative. I wanted to increase that ratio.
Hmm.
And that's where I think my making things better ended up pulling me. And it was more, I can't say I could have never predicted I would be talking like this when I was a student, but things kind of evolved in front of me. And one of the things I see a lot of students wrestling with right now is trying to be very deterministic in terms of their careers. What is it exactly they want to do? Um, Boy, I was never that way. In fact, I would encourage people not to be that way, but to more take advantage of the things that pop up in front of you. Most of my opportunities were questions I couldn't see coming. I could have never seen the invitation to go to China or
Hmm.
the invitation to work at Gates or things like that. I could have never predicted that those were coming. I wasn't gunning for those. I wasn't applying for those. They suddenly popped up.
Hmm.
So how can you design things and be in a place where things pop up, where opportunities come onto your radar screen, and for you to say, well, that sounds different. It doesn't sound necessarily linear with my path, but I'll do it. So, so that's how I've kind of thought, and it's broadened beyond maybe what I would call a traditional clinician pathway.
Yeah. One of our earlier guests said something similar. They said, it's hard to imagine that I would be at this moment doing all the things that I had done. And it goes to show how it really is difficult to plan so neatly for a career path. Things sort of just happen. So I really like that piece of advice for audience members. Um, Finally, for our last question, I always ask our guests, what are some book or media recommendations that you would recommend for audience? What are like in particular books that you have found change your ways of thinking, that you think that we would really benefit from looking into?
Um, wow, I have to
Yeah.
be uh, reflective here, and maybe end up citing some authors. Um, I wish I was better at remembering specific names and specific books, but there are a couple of ones that are kind of old standbys for me, and they're a bit old, but I still think they're good and they're relevant. One is the book Good to Great, which was really popular in business circles,
Hmm.
but it's for systems thinkers. It's a book on how do you try and organize and move systems from a good to a great threshold, and I always found that to be a really helpful book. Uh, the Innovator's Dilemma, which is out of the Harvard Business School. Because again, for people who are trying to work on solutions, working on creativity, and no matter what field, um, how do you actually take that? We're all kind of structured to work within the system,
Hmm.
but how do you actually bring the creativity to making the system better or making the system different? Another book that really changed my way of thinking is by the New York Times author Tom Friedman, called The World is Flat. And again, a little bit of an older book, but for so long, so many people have really been compartmentalized, and their geographical focus has been dominant, and they
Mhm.
haven't been able to think beyond those boundaries and those confines. And I found that book to be particularly helpful and good. So those are a few that come to mind, Neil.
Yeah. I think those books themselves, those recommendations that you gave, really do show the interdisciplinary way that you've approached your work, and the multidisciplinary thinking that you yourself have. Well, thank you so much for joining us. I found this conversation incredibly thoughtful and insightful, and I think a lot of our audience members who are interested in global health work will really benefit from hearing about your experiences and the lessons you've learned from those decades engaged in global collaboration. So, once again, thank you so much.
Well, thank you for hosting this, Neil. And as I think you know, I'm a huge fan of NAMA Next Gen. So really applaud and appreciate your good work. So good talking with you.
Great talking with you. We really appreciate your praise.
Sure. Thank you.
Thanks for listening to Voices from the Field, the Next Gen podcast. If you enjoyed this episode, please make sure to follow us on Instagram, Spotify, Apple Podcasts, and YouTube to stay updated on our upcoming episodes. We'll catch you next time on Voices from the Field.